Welcome to Medicine Dish. I'm Jim Lyon, Health Insurance Specialist in the CMS Tribal Affairs Group and your host of today's Medicine Dish. This broadcast will feature CMS and IHS experts providing an overview of the Medicare and Medicaid Electronic Health Record, EHR Incentive Program. All this and more on today's installment of Medicine Dish. Again, welcome to Medicine Dish. As I mentioned earlier, today's topic is the Medicare and Medicaid Electronic Health Record Incentive Program. But first, let's take just a minute to review what the Medicine Dish is and how you can use this information. The Medicine Dish introduces you to a variety of topics pertinent to healthcare programs operated by the Indian Health Service, tribes, tribal organizations, and the urban Indian health programs. Medicine Dish is now broadcast on the third Wednesday of every other month at 1:30 Eastern Time and can be seen over the web through a partnership with the National Institutes of Health at videocast.nih.gov. The next show will air on October 20th. All of the shows are archived at videocast.nih.gov and are easy to access if you can't watch the regularly scheduled time or want to review the information. And now let's turn to the topic for today's Medicine Dish broadcast, the Medicare and Medicaid Electronic Health Record Incentive Program. This is our second in a series of shows about these important programs. Today you'll hear perspectives from the Centers for Medicare and Medicaid Services and the Indian Health Service. I'll now turn the show over to David Nolly, our moderator for today's show, to introduce you to our experts and tell you a little more about what to expect.
Thanks, Jim. Our nation's healthcare system is undergoing an unprecedented transformation that will improve quality, safety, and efficiency of care. The Health Information Technology for Economic and Clinical Health Act, also known as the HITECH Act, established programs under Medicare and Medicaid to provide incentive payments for the meaningful use of certified electronic health records technology. Electronic health records, or EHRs, can help improve patient care in ways that paper records can't. Not only can EHRs improve patient and provider convenience, but EHRs can also improve the quality of care that patients receive by helping healthcare providers identify potential safety issues and better follow up with patients on long-term care goals. But turning paper records into digital ones is not enough. EHRs can only deliver their benefits when the information is standardized and structured in uniform ways. Similarly, EHRs cannot achieve their full potential if providers don't use the functions that deliver the most benefit. For example, exchanging information and entering orders through the computer so that decision support functions and other automated processes are activated. Meaningful use of EHR technology has the potential to prevent medical errors, cut unnecessary healthcare costs, decrease paperwork, and improve the quality of healthcare for all Americans. To encourage the widespread use of this important technology, the Medicare and Medicaid EHR incentive programs will provide incentive payments to eligible professionals and eligible hospitals as they adopt, implement, upgrade, or demonstrate meaningful use of certified EHR technology. These incentive programs, which begin in 2011, are designed to support eligible professionals and eligible hospitals in this period of health IT transition. They will instill the use of EHRs in meaningful ways to help our nation build an infrastructure that allows everyone to benefit from a modernized, interconnected, and vastly improved system of healthcare delivery. Today, we're going to hear from experts on the Medicare and Medicaid incentive programs. We'll learn who is eligible for each of these programs and how eligible professionals and hospitals can demonstrate meaningful use of certified EHR technology. In addition, we'll hear about what the Indian Health Service is doing regarding their use of electronic health records and health information technology. I'm pleased to welcome Elizabeth Holland and Jessica Kahn from the Centers for Medicare and Medicaid Services, also known as CMS, and Dr. Teresa Cullen, Chief Information Officer for the Indian Health Service. Thank you for joining us today. The Medicare and Medicaid EHR incentive programs are exciting initiatives for promoting the adoption and use of health information technology. With the prospect of possible incentive payments for using electronic health records, we're very interested in learning more. So please, give us a brief overview of the program.
The Medicare and Medicaid EHR Incentive Program is about enabling healthcare providers to adopt and meaningfully use certified EHR technology. In the final rule that CMS published in the Federal Register on July 28th, we talk about the policies that we have put into place for providers around eligibility, reporting, and payment of the EHR incentives.
How can a provider get certified EHR technology? And what if they already have an EHR system?
Well, all EHRs will have to be certified for the Medicare and Medicaid EHR Incentive Program. The Office of the National Coordinator for Health Information Technology, or ONC, is establishing ONC-authorized testing and certification bodies this summer. ONC projects that certified EHR software will be available by the fall of 2010. More information on certified EHR technology is available from the ONC website. And we'll talk later about what the Indian Health Service plans to do about certification.
You also mentioned meaningful use. Just what exactly is meaningful use, and why is it important to the incentive programs?
Well, the Recovery Act specified 3 components of meaningful use in the law: the use of certified EHRs in a meaningful manner. The second was use of certified EHR technology for electronic exchange of health information to improve health care, and use of certified EHR technology to submit clinical quality measures and other such measures as designated by the Secretary of Health and Human Services.
If I could, I'd like to give an example that we use with providers, and that is with telephones, with mobile phones. So some people have a basic cell phone that they use to make calls, and that's about it. And other people have what's called a smartphone that has all kinds of applications that help them figure out where they have an appointment and when it is and what's the location, and they can text and they can video and they can keep in touch. It's really changing their lives. So the ability to move from just an electronic health record to really meaningfully use it so it transforms how you run your life is the difference between having a cell phone that you just make calls on versus having a phone that is really a tool now for how you manage your communications in your life.
How was meaningful use determined?
Well, the definition of meaningful use for 2011 and 2012 came about through a very extensive process. We worked through the National Committee for Vital and Health Statistics. They had some hearings for us to get public input. The Health Information Technology Policy Committee gave us recommendations. We conducted extensive listening sessions with providers and organizations. We published a notice of proposed rulemaking where we asked for public comments, and we received over 2,000 comments. And many of them were on all of the meaningful use objectives that we published. We have finalized the definition, as I mentioned, for 2011 and 2012 in the July 28th Federal Register notice.
So for the start of the program, this is just stage 1. Can you tell us a little about this stage? What are the requirements?
Well, essentially, from the definition we proposed in our proposed rule to the final rule, the definition has changed a lot. In the proposed rule, we had introduced an all-or-nothing approach, where providers would have to do all of the meaningful use objectives. We heard loud and clear that providers wanted more flexibility. So we've enabled them to have some degree of choice, and we've lowered thresholds. And we've also determined that no measures will require manual chart review to calculate the thresholds. So for eligible professionals for Stage 1, there are 15 core objectives. In addition, they can choose objectives from a menu set. So 15 core and then 5 from the menu set means they'll have to report on 20 measures. For hospitals, there are 14 core objectives, and then they'll have to choose 5 out of a menu set of 10 for a total of 19 measures. In addition, there are also clinical quality measures that they'll have to report. Eligible professionals will have to report on 6 total clinical quality measures. There is a set of 3 core measures, and then if you can't meet those 3, you will be offered 3 alternative core measures. In addition, you'll have to report on 3 additional quality measures from a set of 38. Eligible hospitals will need to report on 15 clinical quality measures. There will be stages 2 and 3, and we will be defining those in future rulemaking.
This is a great start, but I'd like to know a bit more about some of the specifics of the Medicare EHR Incentive Program. So, Elizabeth, who can participate in the Medicare Incentive Program, and how was eligibility determined?
Well, eligibility, we really followed the law. What was in the Recovery Act, those are the eligible professionals. The law specified that eligible professionals for Medicare would be doctors of medicine or osteopathy, doctors of dental surgery or dental medicine, doctors of podiatric medicine, doctors of optometry, and chiropractors. I know, Jess, it's a little different for Medicaid, isn't it?
Right, so in the Recovery Act, it was established that Medicaid eligible professionals include physicians as well, though the definition of a physician is based on each state Medicaid program's determination of what is a physician and physician services, as opposed to the list of the different kinds of doctors that Elizabeth described. In addition, eligible professionals for Medicaid include nurse practitioners, dentists, certified nurse midwives, and physician's assistants. However, that's a little particular. It's only physician's assistants who work at a federally qualified health center or a rural health center that is led by a physician assistant. So all of those 5 different professional types constitute a Medicaid eligible professional.
And in addition, we also have eligible hospitals for the incentive program. For Medicare, an eligible hospital is an acute care hospital, which we define as a subsection D hospital. In addition, for Medicare, critical access hospitals are also eligible. It's a little different for Medicaid as well.
Right, so for Medicaid, the statute had said that we had to include acute care hospitals and children's hospitals. But initially, we didn't include critical access hospitals as part of our definition of acute care. However, in our final rule, due to public comment, we were able to expand the definition of an acute care hospital for Medicaid so that critical access hospitals are included.
How much are the financial incentives in the Medicare program?
Well, under Medicare, the incentives are based on 75% of allowed charges for eligible professionals, so that for calendar year 2011, the maximum would be $18,000. That would be the incentive. In addition, if you happen to be practicing in a health professional shortage area for Medicare, you could receive an additional $1,800. The maximum total incentive payment for an eligible professional is $44,000 if they participate in all 5 years and start in 2011 or 2012. But for Medicaid, the incentives work a little differently for eligible professionals.
So under Medicaid, the maximum an eligible professional can receive over 6 years is $63,000 and change. The first payment that they receive is $21,250. That's the largest payment, and then it's $8,500 a year for subsequent years. And we derived that amount by doing a study about the average allowable cost of electronic health record technology and determining what would be 85% of that, because that was what the statute instructed us to do.
When does the Medicare EHR Incentive Program begin?
The Medicare EHR Incentive Program, the registration will begin in January 2011.
And for states, it's slightly different. We should note that CMS is going to implement this program. That was what we were instructed to do in statute. However, the statute allowed for states to voluntarily decide if they're going to have a Medicaid EHR incentive program, and if they do, when they're going to implement it and what that timeline would look like. So we anticipate that 20 to 25 states are going to be ready to launch their programs in January, and the rest coming on later in 2011.
What if they are already participating in a CMS incentive program, like Physicians Quality Reporting Initiative or e-prescribing? Can they also participate in the Medicare EHR incentive program?
Well, for Medicare, it depends on which programs they're participating in. If they are participating in the Physician Quality Reporting Initiative, yes, they can also get an incentive from the Medicare EHR incentive program. However, if they are participating in the e-prescribing incentive program, they are not able to get an incentive from the EHR incentive program as well. They would have to choose between the program. But I think, Jess, it works a little differently for Medicaid.
It is different. Under the Medicaid program, they can receive an EHR incentive, and also if they're both a Medicare and Medicaid provider, which is not uncommon, they could also receive the e-prescribing incentive. This is a good example of a frequently asked question that CMS has on our website about how our different quality and incentive programs interact.
Okay. What does an eligible professional or hospital need to do to get started? When and how do they register?
Registration will be opening in January, and they will register through a website, and then they will need, initially, for Medicare, there's a 90-day reporting period, and then they can come in and attest to us that they're using a certified EHR and that they have met meaningful use. They'll have to provide us with yes and no answers for each of the meaningful use objectives, or give us numerators and denominators. Same for the clinical quality measures that they've chosen to report. So attestation will begin in April, and then we expect payments will start being made in May. And that's also a little different because Medicaid doesn't necessarily have to report meaningful use in their first year.
Right. So states, we decided to follow up on Elizabeth's point that it made more sense for eligible professionals and hospitals to have one front door into this program. So whether you're a Medicaid or Medicare provider, or maybe you don't know yet where you belong based on eligibility, this one website would be your first stop, your destination. And we will have decision support and tools on the website for you to figure out where you may or may not be eligible. And then on the Medicaid side, after we have collected a certain amount of information from the eligible professional or hospital at that one front door, that gets shipped to the state, and the state has to complete the eligibility determination, and then they will take the data that Elizabeth mentioned around attestation, and the states make the payment for the Medicaid providers.
What about hospital-based providers? Are they eligible to participate?
Well, a hospital-based eligible professional is one who furnishes 90% or more of their services in either an inpatient or an emergency room department of the hospital. And hospital-based EPs will not qualify for Medicare or Medicaid incentives.
What happens if an eligible professional or hospital decides they don't want to participate in the program?
This is a voluntary program. They don't have to participate if they don't want to. However, for Medicare, if they do not participate or if they do not successfully demonstrate meaningful use by 2015, they will be subject to payment adjustments, so we will be reducing their Medicare payments.
Interesting. Do eligible professionals and hospitals have to sign up right away, or is there an end date by which they need to start their participation into the incentive program?
They don't need to sign up right away, but there are end dates. If you sign up and you're an eligible professional and you sign up in 2011 or 2012, your total incentives could be greater than if you wait longer. And for Medicare, you need to sign up by 2014. I know, Jess, it's a little different for Medicaid.
Right. For Medicaid, I should mention we have a slightly different on-ramp, and there is no penalty for waiting. The incentive that you would receive, it depends on your first participation year. But I wanted to mention that for the Medicaid program in the statute, it allowed for providers to receive an EHR incentive payment, and this is both the professionals and the hospitals, for adopting, implementing, or upgrading certified EHR technology. So they have a year to get their feet wet, to get involved in using the EHR, to figure out how it works, to make sure it's the newly certified version, and then in their second and subsequent years, and they have up to 6 years of incentive payments in Medicaid, then they have to demonstrate meaningful use.
Is there a minimum patient volume to qualify?
Only for Medicaid. As Elizabeth mentioned, there are claims related to the Medicare program, and whether or not you're eligible, you have to have Medicare claims. However, under Medicaid, in the statute, again, these are thresholds that CMS did not define. Eligible professionals, aside for pediatricians, have to have 30% of either their Medicaid patient volume, so those are Medicaid encounters, and we define that in our rule fairly flexibly, or if they work at a federally qualified health center or a rural health center, they have to have 30% of their patient volume be needy individuals, such as Medicaid, CHIP, sliding fee scale, or free care. In addition, a pediatrician only has to demonstrate 20% of his or her patient volume, so it's a slightly lower threshold. However, then they only receive 2/3 of the incentive payment amount. And then an acute care hospital under Medicaid, which again includes critical access hospitals, has to have 10% of their Medicaid patient volume. The only Medicaid eligible provider that doesn't have any patient volume threshold to qualify are children's hospitals.
Which kind of led to my next question. Would patients in children's health insurance program also count in the minimum patient volume?
They do, only for those providers, those eligible professionals who work at a federally qualified health center or a rural health center. It does not count as Medicaid patient volume outside of that setting.
Okay, so now hospital-based providers can't participate in the Medicare EHR incentive program. Can they participate in the Medicaid incentive program?
No, there are many places that we've tried to have a harmonized policy guidance to states and to providers, and this is one example. Hospital-based eligible professionals is a consistent policy through the rulemaking and through the statute for both Medicare and Medicaid.
Can eligible professionals participate in both incentive programs at the same time?
Unfortunately not. Eligible professionals will have to look and decide whether it would be more advantageous for them to participate in the Medicare or the Medicaid programs, and they'll have to make a selection.
However, on the Medicaid side, a provider not only has to choose Medicaid as opposed to Medicare if they're eligible for both, they also have to pick a state. They can't receive an incentive payment. Even if they provide care across border settings, they still have to pick one state to receive an EHR incentive payment from Medicaid.
Which hospitals are eligible for the Medicare incentive programs? Can hospitals participate in both programs?
Well, let Jessica talk about the hospitals that are eligible for Medicaid, and then I can talk about whether they can participate in both.
Sure. So like I mentioned, we have acute care hospitals, which under Medicaid include critical access hospitals, and we have children's hospitals. And then on the Medicare side,
we have subsection D hospitals as well as critical access hospitals. And what we decided to do to make things easier, or if hospitals, Medicare hospitals, come in and successfully demonstrate meaningful use, and if those hospitals are also eligible for Medicaid, we will deem that they are eligible for a Medicaid incentive as well. So you could get hospitals that are eligible for both programs could get an incentive through Medicare and Medicaid.
Right, with the exception of the children's hospitals. This just applies to the subsection D and acute care hospitals, and critical access, which is a large number of hospitals in this country.
Okay. What is the overall size of the financial incentive for the Medicaid program? Is there a formula by which an eligible professional's total incentive is determined?
Sure. So as Elizabeth mentioned, under Medicare, an eligible professional can receive up to $44,000 in total over 5 years, depending on their claims threshold. Medicaid is slightly different. Under the Medicaid program, the statute asked us to do a study to look at the average allowable cost for adopting a certified EHR, and we did so, the Secretary did so, and then we had a cap within the statute of what we could provide to an eligible professional per year, and we justified that that amount in the statute, which was $25,000, was less than what the average allowable cost is for adopting EHR technology. So therefore, an eligible professional can receive up to 85% of that. So in their first year, they would receive $21,250, and in the subsequent 5 years that they participate in the program, they would receive $8,500 each, and this is just for eligible professionals. The hospital formula, as she mentioned, is somewhat more complicated and involves looking at Medicaid and Medicare discharges and with a base amount, and there's no one amount for all hospitals. It's individually calculated.
But it is something that eligible professionals will have to take very seriously, because you can't get your maximum incentive under Medicare and then add together the maximum under Medicaid. You'll have to determine which is most advantageous for you, and then make a determination.
Right, and so the total amount for Medicaid is $63,000 and change, and even if you were to change once between Medicare and Medicaid's program, you'll never get more than that as an eligible professional. And under Medicaid, we do not have the bonus for health provider shortage areas as they do under Medicare.
Okay.
So that's the flat amount.
When do eligible professionals and hospitals have to demonstrate meaningful use of an EHR, and how do they show it? What are the criteria?
That's a good question. In terms of the timing, again, it's up to the eligible professional in the hospital if they want to participate in the program at all. If they do and they are eligible, they need to determine when they have all that they need to be able to demonstrate either meaningful use for Medicare, or that they have adopted, implemented, or upgraded certified EHR technology to Medicaid. So that's their own decision, and they might make that as a group practice, they might make that as a solo practitioner, a hospital might make that determination for themselves as a system. And as we mentioned, they will either attest to that information at the one website for Medicare providers for CMS, or they would have to attest to that information at the state level. And what we mean by attest is it's essentially a system where, like submitting a claim or submitting your taxes to the IRS, you put in information and you verify through an electronic signature that that is in fact true.
Will states have additional requirements?
So we were proposing that states could perhaps tailor the definition of meaningful use to have some state-specific relevance. However, the public commenters, for the most part, were not really in favor of that. They were concerned that, at least for stage one of meaningful use, this might introduce too much ambiguity and difference from state to state. And so on the other hand, states really felt like this is only one of many programs that they are doing to improve quality of care in their state. So they wanted to be able to leverage it to the extent they could. So where we came out in the final rule is that a state may propose to CMS, subject to our prior approval, that they would take some of the public health related meaningful use measures and move them from the menu set that Elizabeth described into the core set. And there are only 4, and they could do 1, 2, 3, or all 4. So moving them from something that a provider could choose to not do, or now moving it to something that would be required. But a state would have to demonstrate that to CMS on a case-by-case basis to make sure it's not presenting any undue burden on their provider population.
Well, how will states verify eligibility and disperse payments to eligible professionals?
So states are going to have to accept provider attestation about a number of things. They'll verify that the providers are in fact licensed and not sanctioned, and that they are using certified EHR technology, and they would have to accept their attestation on the patient volume requirements that we talked about. And then they will disperse their payments to them through the tax ID number that each individual professional or hospital gives to the state. And so they have to already have some payment relationship with the provider prior to initiating the payment.
When does the program end, and how long do eligible professionals have to register?
Well, there's a different answer for Medicare and for Medicaid. For eligible professionals, they need to sign up for the program by 2014, and the program will end in 2016. For Medicaid,
it depends on when the state launches the program. They can register, as we mentioned, for CMS starting in January. However, states have their own timeline when they're going to implement the program. We have approximately 20 to 25 states that are anticipating launching their program in January of 2011. And so at that point, once they have launched, and we expect the rest to come on before the summer, the providers could register. They have up to 6 years that they can participate, and they don't have to be consecutive years, so they can have some false starts in there if they have to. And they have through 2021, so this is a decade-long program under Medicaid. However, they can't initiate their participation any later than 2016, so they have to start the clock in 2016.
Okay. Lots of good information there. If eligible professionals are looking for more information or if they have additional questions, what resources are available to help?
So there are actually a lot of resources that are being deployed to help providers determine what they need to know about this program. Some now and then some more so starting in January. To start with, the CMS website has a lot of good information on it. It has information about who's eligible, how to determine if I'm eligible. For example, since we have Dr. Cullen here today, if I work at an Indian Health Service clinic or a federal facility, am I an eligible professional? If you meet these other criteria, the answer to that is yes. In addition, if you are looking for more information about certified EHR technology, it would have you go to the Office of the National Coordinator's website. States have information on their websites and are continuing to add more information because, again, states are implementing the Medicaid program. CMS is adding more information to our website. Also, the CMS regional offices are able to respond to provider inquiries. They have a lot of information available to them. They are tracking the questions, and if they can't answer your question, they will make sure that they find out who can and will refer you to the right place.
All right. Well, thank you so much. Thank you to both of you for a lot of good information this morning. But for now, we're going to turn to Dr. Teresa Cullen, the Chief Information Officer for the Department of Health and Human Services Indian Health Service. Welcome, Dr. Cullen.
Thank you.
The Medicare and Medicaid EHR incentive programs and the advances in health IT through the Recovery Act are also key pieces of interest for IHS. Dr. Cullen, tell us what IHS has been doing to support health IT.
You know, sometimes I feel like the Meaningful Use program was designed for us to some extent. We've been really lucky. We planned ahead. 25 years ago, we developed a health information technology system. Most of you know that as our PMS. In 2001, we started doing electronic clinical quality reporting, the first EHR in the country that was able to do that and aggregate data. In 2004, we started deploying what you know in Indian country as the RPMS EHR, which is the graphical user interface. The graphical user interface is, in fact, what most people are referring to when they refer to an EHR right now. But Indian country has been really lucky in that we have over 25 years of how to utilize a health information technology system to improve care. We've been able to integrate that into our goal of achieving health equity, decreasing disparities. So when you look at what is happening now and you look at the components of meaningful use, you should recognize that as part of the care you give right now. That includes you're using a certified EHR, and I can talk briefly about that in a second. You already know how to share data. You've been doing it with your immunization exchanges, your reference labs. We did H1N1 early surveillance last year in a week. We stood up that surveillance system, and as you know, we've reported that to the EPI programs. And finally, clinical quality, which is an integral part of what we've been doing, not only in the normal delivery of care, but also as part of our improvement in patient care, our IPC initiative. So I think from an Indian country perspective, the sites that have been up on RPMS and our health IT system are poised to be able to take advantage of the meaningful use incentives.
How does your work relate to the Medicare and Medicaid EHR incentive programs, as well as the IHS Director's priorities?
Thank you for that question. Let me start with the Medicare and Medicaid EHR incentive program. As was already elicited by Jess and Elizabeth, you should be able to see that we are eligible, which is great news. And the vast majority of our sites, we believe, will be able to qualify under either Medicare or Medicaid, depending upon the choices they have and what their user population is. We've worked really closely with Medicare and Medicaid over the last year, as well as the Office of the National Coordinator, to ensure that tribal needs and what we believe are the tribal responsibilities have been elucidated and shared with both CMS and the Office of the National Coordinator. Overall, I think that the collaboration and the cooperation that's been shown between all three of our offices within Health and Human Services has been exemplary. And I think it's because there is a true commitment to ensure that we can actually improve the way we deliver care. Obviously, we're leveraging Health IT to do that. We've worked with many of your sites already to make sure that you're aware of what's been going on with meaningful use, whether you'll be eligible or not. You need to do certain things, obviously. Meaningful use is leveraged by health information technology, but the ultimate use and confirmation of meaningful use is dependent upon what your providers, your healthcare system, and what your patients are able to do. So in that case, it's critically important that we engage not only your providers, but also your patients and your community early on. We believe that the increases that we've been able to make, for instance, with the development of a personal health record, our launch of encrypted email in the near-to-be future, will ensure that our patients are able to enter into the 21st century with resources that have traditionally not been available for them. In addition, we've focused on literacy, we've focused on clinical quality measures that we believe are appropriate to our communities. As you've heard spoken before, there is selection in the clinical quality measures. You're able to look at clinical quality measures from an eligible provider perspective that will reflect our needs. When we look at the core measures, they're things we've all been doing. We've been doing them for 10 years. The reason why we've done them is because they've been important to Indian people. And so what we want to do is now ensure that you're actively engaged in what we're doing. And I want to go back then to the director's priorities. Interestingly enough, there really is a crosswalk here once again. I think unbeknownst to all of us at the time the director announced her priorities, but things like improving access to care, improving quality of care are critical parts of what we want meaningful use to do. So once again, there's that belief that the health information technology system, for the vast majority of you, RPMS, but also in addition the sites that are using commercial products, can be used to get at our ultimate goal, which I've already spoken about. Finally, I think that the director and the senior staff at the Indian Health Service, as well as tribal leaders, have been involved in this process and are committed to ensuring that we provide you with adequate resources to ensure that you can jumpstart into meaningful use. I say, and I don't say glibly, that IHS plans on qualifying for meaningful use, both for Medicare and Medicaid, in 2011. We're the largest integrated healthcare system out there. We know you have lots of issues, but we believe that we actually can achieve that. And if we can achieve that, we are not only a model for Indian country, we're a model for rural America. Because rural America, most of our partners where we send our patients are struggling with EHR technology. And what we want to do is be able to show them that they can use us as a model and that we need to get their data electronically so we can make sure we can improve care.
Where should our viewers go to learn more about your programs?
So we would recommend that people go to CMS because they have great websites. We'd recommend people go to the Office of the National Coordinator site. But we also have stood up a Meaningful Use website. You can get to it off the main page of the IHS. And we've really focused on what Meaningful Use does. So we've established a listserv. We've done lots of trainings. We're trying to do them in every venue possible, meaning we're coming to your area soon. We're also we are doing WebExes. We're in fact doing some WebExes with CMS. We expect to continue to do them with the Office of the National Coordinator. But I think that there's lots of information out there. We also have a calculator on our website that will enable you to use your data set to determine whether you're eligible for Medicare and Medicaid. Remember, once again, there are percentages of your patients that have to be enrolled and bill Medicare or Medicaid for you to qualify for that. But overall, we believe that we, in the next year, will ensure that you have adequate resourcing and adequate access to information that you'll be able to achieve meaningful use.
Wonderful. Thank you, Dr. Cullen. This is exciting information and certainly important for providers in tribal communities. I want to thank all of our speakers for their valuable contribution to this discussion and for joining us today.
We've covered a lot of information today. I'd like to thank Dr. Cullen, Jessica Kahn, and Elizabeth Holland for sharing their insights on the Medicare and Medicaid Electronic Health Record Incentive Program and its impact on Indian country. For more information about the Medicare and Medicaid EHR Incentive Program and other HITECH Act programs created by the American Recovery and Reinvestment Act of 2009, go to www.cms.gov/HITECH. We're at the end of our Medicine Dish show, and I want to thank you for your participation in our broadcast. Our next broadcast will be on the third Wednesday of October. That's October 20th at 1:30 p.m. Eastern Time. And remember, you can access previous Medicine Dish programs at the NIH website, videocast.nih.gov. To find the shows, go to Past Events, select Lecture Series, and then select Centers for Medicare and Medicaid Services. Thank you, and I hope you enjoyed and benefited from today's Medicine Dish show. I'm Jim Lyon, today's host of the Medicine Dish, wishing you a very productive day.